Hi there, welcome to this IPRS Health webinar on knee osteoarthritis. Today, what we're going to talk about is the knee joint itself, what knee osteoarthritis is, what the risks are for developing knee osteoarthritis, some of the myths and facts for knee osteoarthritis, and what are your options in terms of treatment and management of knee osteoarthritis. So, first of all, let's have a look at the knee. It always helps if we understand a little bit more about the anatomy of the knee and how that relates to pain. So if we have a look at the knee here, we've got some obvious landmarks on there. So we've got the medial ligament. Now medial is another word for the inside, so that's the ligament on the inside of your knee. The lateral collateral ligament, which is the ligament on the outside of your knee. Lateral is another word for outside. And the same for the meniscus. Now the meniscus is a thin piece of cartilage that helps to cushion your knee and shock absorb while we're walking and running and jumping and doing all of those things. And the patella in the middle is our kneecap. The bone above is our femur, which is our leg bone, and the tibia is below, and that's our shin bone. But the area we're interested in terms of osteoarthritis is this blue bit here, which is what we would term the articular cartilage. So we can see the other things around it that we've just discussed, the medial and lateral meniscus underneath, and the articular cartilage is the part that is affected most by knee osteoarthritis. And that's a thin layer of cartilage that helps protect the surface of the bone. Now what can happen over time is some of this cartilage breaks down a little bit and might wear away a touch, and this is where knee osteoarthritis develops. So what is knee osteoarthritis? As I've just said, it's a breakdown of that articular cartilage and some of the other structures around the knee, but predominantly that articular cartilage. It can lead to varying levels of pain for different people, as there's a little bit less cushioning around that knee. As it attempts to regrow over time, this is what can lead to some stiffness in the joint, and often that's what you feel first thing in the morning. So if it's stiff first thing in the morning when you wake up, it's often because of this reason. And obviously, as you will all know, as sufferers of knee osteoarthritis, it can affect your overall function and day-to-day general living. So what are the risks? What are the things that predispose us to developing knee osteoarthritis? The first thing is age. So it seems that in the research, when we look at it, it's over 50 that is predominantly affected. And now this knee osteoarthritis can be attributed as a normal change with age. That's not to take anything away from it. That's not to say it isn't painful and isn't something we should do something about, but it seems to be a normal part of aging. Gender: females are more likely to develop knee osteoarthritis than males. Genetics: so if your siblings, parents, close relatives, grandparents have had knee osteoarthritis, that does predispose you to developing it yourself. Body weight: a higher BMI has been shown to predispose someone to knee osteoarthritis. Previous injury or surgery: so when we look back at our knee anatomy, it's that meniscus that we're talking about particularly. So if you've had a previous injury, it might be an ACL tear, might be a meniscal repair in your younger years, that can predispose you to developing osteoarthritis when you're older. And now the last one is heavy loads and repetitive loading. And there's a question mark over that, because this is something that's traditionally thought to be a real risk for knee osteoarthritis. You know, you've heard it before many times, I'm sure. Or don't run on the roads too much, you'll wear out your knees, or don't do that too much, you'll wear out your knees. When actually that doesn't seem to be the case. So they did a big study last year on thousands and thousands and thousands of marathon runners, and found that marathon running was actually protective against knee osteoarthritis compared to those who didn't. So running is not inherently bad, and it doesn't seem to predispose us to knee osteoarthritis. And it's probably likely the same for heavy loads at work and things. There's lots of factors there, as you can see, that influence why you might get knee osteoarthritis, and it's never just one thing. So just because you've played a lot of football in your life, or netball or hockey, or you've had a manual labor job, does not predispose you to knee osteoarthritis as much as we previously thought. And as you've seen there, there's 4 other things that can equally contribute towards you developing knee osteoarthritis. So when we think about myths and facts, I've mentioned a couple already. Let's go through some others. So the more I do, the more wear and tear there will be. As we just alluded to, that's not always the case. And exercise is bad for your knees. They kind of go hand in hand. Now, this isn't always the case, and it doesn't seem to be from the research that's coming out at the moment. Exercise is most certainly a really, really good thing for you to do for your knees. The more you exercise, the more cartilage you can help produce, which means the healthier your knee stays for longer. Exercise is very, very good for your knees. The more you do, the more it'll wear out. That again doesn't seem to be the case, and even if there is some wear and tear there, it doesn't correlate very well at all to the level of pain that you're in. So if you look at an x-ray or a scan of your knee, it might look like there's lots and lots and lots of wear and tear, and you might not be in much pain at all. And equally, there could look like there's very little, and you could be in higher levels of pain. There's lots of different things that contribute why we might experience pain, and it doesn't correlate very well to damage in the tissues. So just because it hurts doesn't mean there's harm, and just because there's pain doesn't mean there's damage. So working and exercising your knees is actually a very good thing, because it doesn't correlate very well with the amount of damage that's in your knees. I have inflammation in my knee joint. So inflammation isn't always present, and that's why you may have taken things like ibuprofen or other non-steroidal anti-inflammatory drugs in the past, and they might not have been as effective for your knee pain as you'd hoped, and that's sometimes because inflammation isn't the main proponent of pain. It's not what's driving that painful experience for you. So there doesn't have to be inflammation there for it to be painful for you. Acupuncture is useful. Unfortunately, it's been shown that acupuncture and other passive treatments like massage, manipulation, things like that, are not particularly good for pain in the knee or anywhere else for that matter. And active treatments such as exercise and lifestyle changes are much, much, much better at reducing pain and giving you some long-term benefits. I will definitely need a knee replacement at some point. Again, only 25% of people with knee osteoarthritis go on to have a knee replacement. So if you can manage your lifestyle in such a way that's beneficial, then it's unlikely that you will end up going for surgery. You could push yourself into that 75%, which never needs surgery, and that they manage pretty well without it. So, what are the treatment options? Surgery, as we've just said, it is an option for knee replacement. Now, the thing with surgery is once you have it done, there's no going back. It will need to be revised every 10 to 15 years. There's inherent risks that go along with having a surgery. So knee surgery is an option, but it most certainly shouldn't be the first option, and all other options should be exhausted initially before surgery is even thought about. Injections, so you can get a corticosteroid injection potentially that helps reduce pain in the knee, and again, that's only a very short-term fix and shouldn't be thought of as a long-term solution. And rather than a delay to surgery, an injection should be something that you get to reduce pain, to get you back into doing some physical activity, modifying those lifestyle changes to make sure that we're increasing our exercise levels, rather than just prolonging surgery. If an injection is used in a positive way to get us back into exercise, then that's brilliant. Exercise and physiotherapy, and the gold standard at the bottom there, exercise education and physiotherapy, which is partly what this webinar series is for, is to give you a greater understanding and education about what knee osteoarthritis is and about all the other elements that can help contribute towards reducing your experience of pain. So it kind of goes in a linear relationship like this. We should, at the gold standard for conservative care for knees, is exercise, education, and physiotherapy, working with a physiotherapist who can manage your symptoms, who can help guide you through an exercise regime, who can give you some good education around knee osteoarthritis. Those three things combined are really successful at reducing pain in the knee if the changes are made. This is also an important point. It's not always about the knee. We shouldn't just concentrate on the knee. The knee is attached to you as a person. Strength and knee condition are important. We're not going to take that away. It's good to be strong in the knee. It's good to improve the lower limb strength. That can help towards reducing pain. But so can diet, nutrition, and lifestyle. When we think back to our risk factors, BMI being one of them, it's a modifiable risk factor. So if we can change that BMI through diet, nutrition, and lifestyle changes, then we can have a positive effect on knee pain. Weight, again, goes in that same category. Beliefs and fears, so managing what we think is dangerous for our knee. So thinking back to some of the myths and facts we were talking about, there are many people with knee osteoarthritis that believe physical activity and exercise are bad for their knees and they shouldn't do it. If we can address those beliefs and fears and we can start to get engaged with some physical activity, that again can have a positive effect. Having a good support network around you, friends and family and colleagues that understand what knee osteoarthritis is, which you can be part of in terms of education, that's really important that they're supportive around you to help you integrate these positive lifestyle changes that we're hoping you're going to make. Maximizing your opportunities for physical activity, really thinking about what it is that you enjoy doing, what you have access to, what you think you're going to stick to. Those are all really important considerations to make, and there's a further webinar in this webinar series that addresses this physical activity. So the key messages from this initial webinar on what is knee osteoarthritis: your pain has multiple contributors. It's not simply one thing that's a risk factor, like heavy repetitive loads. It's not as simple as loading your knee equals pain. There's lots and lots of different contributors, as we saw: genetics, age, BMI. There's lots of different things that might influence the experience of pain that you have. You have the ability to change your pain. Talking about risk factors as we did, there's some really good modifiable risk factors in there: physical activity, exercise levels, BMI, fears and beliefs and attitudes. There's lots of things in there that contribute towards pain that we can help to modify by working with your physiotherapist and getting good education on the topic. And the biggest take home I want you to get from this is that exercise is good for your knee. Despite what people may have said before, despite what you may have heard elsewhere, exercise is paramount in improving your symptoms and or maintaining them. If your knee isn't too bad at the moment, exercising it and keeping it healthy are really important moving forward. Thank you very much for listening, and I will speak to you again soon.